Welcome to The Bridge, Your Health, Your Voice, the official podcast for the University of Maryland, Baltimore School of Pharmacy Patients Program. The Patients Program is the bridge between the community and researchers. The Patients Program created this partnership to help researchers listen to the community's voice in order to build a bridge to an effective learning healthcare community. Here's your host, Rodney Elliott.
I want to thank you for joining us again, and to our listeners, I'm sitting here talking to Miss Alita. She is a member of the PPA, Patients Professors Academy, and if you're new to the bridge or new to our voice, you probably don't know what the PPA is, but if you aren't, and you've heard us before, you know the PPA is a curriculum that Patients Program started a couple of years ago. We're going into our third year where we have researchers, community members, advocates, caregivers, all together, getting together during a 6-week program, trying to understand how to bridge the gap when it comes to community engagement. And they have online sessions, everything's online, but they also have these course topics where we have some researchers, professionals talk about it, but then we also have folks who have lived experiences that are professionals in their own right, and they share in the presentation part. And today, we have one of our guests. Again, she's not new to the Patients Program, but I'm going to give her an opportunity to introduce herself to our listeners. So, Ms. Alita, you don't mind giving us a quick intro to who you are and what you do?
Sure, I'll be happy to. Well, my name is Elita Hill, and I'll do an accessibility intro. So I'm a Black woman with cornrows and kind of grayish hair in the front. I have glasses on and a light beige shirt with blue pearls and a blue background. I'm currently in Charlotte, North Carolina, and I have an eclectic background, which is why I actually find it an honor to be part of the Patients program. And so I currently work as an American Sign Language interpreter, and that has been a field that I've been in for over 40 years. I would say that's my secondary career, but formerly I was in public health and public health research. And I would say that my leaving public health, my passion, it's just my joy, is a result of what I would call moral injury. I could no longer be what I would classify as playing the role of Lady Macbeth in making decisions about communities that was clearly harmful and not really being able to do much about it. And so I left my field of love, and thankfully I'm grateful that I had a secondary skill and career. And so now I have transferred that into sign language interpreting, and I'm here with Patients Program just kind of to offer a different lens.
You know what? So it sounds like sign language and interpreting was just soft place to land post your passion when it comes to health and representing folks in marginalized community. My background was basketball, and my soft place to land was helping community members, and I always wanted to help kids, so to speak. So years ago, I decided to partner with Dr. Mullins, and then obviously become a part of the Patients Program. And when you have a soft place to land, so to speak, to kind of still do what you want to do, but do it at your own pace, I think that's important nowadays. You mentioned earlier that you wear glasses and you have gray hair and cornrows. I think we got 2 out of the 3 together with that. I wear glasses. My beard is gray, but I wish I had cornrows. If I could get a cornrow on top of this head, that'd be great for me, but I don't have that. But what we do have is we both enjoy helping out communities. We both enjoy finding ways to stay connected with our communities. And before we get into today's discussion, I just wanted to ask you, Ms. Alita, how did you find out about the Patients Program? How did you find out about the PPA? Where did that come from? Where did that email come from, I would say, probably?
Well, honestly, the email came from Joe Allworth.
Yeah.
And he and I had an amazing opportunity to encounter each other here in Charlotte. The two of us were involved in some racial equity work here in the Charlotte area. And so we just through a variety of conversations, just kind of doing the work locally. And then he finished his PhD program here in Charlotte.
Yeah.
Off somewhere, and he resurfaced in an email to me inviting me into the program, and I thought, Joe, are you serious? You're inviting me into the Do you know my position, right, Joe? So and so so that's how I found out about it. Mm-hmm.
Joe knew where to go. And if you know Joe will send you an email or two and make sure he stays connected with you and provide an opportunity to for you to kind of share your expertise, so to speak. And I'm glad he did, because Ms. Alita, you have been a great contributor to the PPA success, which is why we're here today to talk about your role. But now that you've been part of the PPA, how would you define or describe what health equity means to you within the context of the community that you serve?
Right. So the community that I serve, so I look at my role as a person who serves the communities holistically. Okay. I don't necessarily kind of focus in on, as a sign language interpreter, the deaf community as being the community that I serve, because as an interpreter, I am in between both. I'm in between a lot of communities. And so if everyone knew sign language, there would not be a role for me in the middle. So I do view my positioning as one who is in service to the entire community. I think that also is informed from my public health background, that public health is about the public as a total entity. And this question of health equity, recently I have been humbled by not being able to define it. Actually, and looking at some current research, there's about 6 or 7 different definitions floating around out there. We tend, and I mean, we just kind of as Americans or people, we tend to latch on to phrases and terminology very, very quickly before we really define the concept of what we're talking about. And so we end up using words and making assumptions that we are all thinking in our thought bubbles about the same thing just because we're using the same words. And I really think that is going to be a huge challenge in the very, very, very near future. I live in a state who is one of 28 states that is actively pushing forward anti-diversity, equity, inclusion legislation. While it's happening on the higher education level, it is filtering down into local government. And a really big concern is one of my representatives in Congress has actually put forth legislation this past year that would bar medical schools from getting federal funding for any efforts related to diversity, equity, or inclusion programs. And I was just reading literally this morning that a similar bill has been taken up in the Senate. And so it's not merely the title. They are crafting language that says any medical school that embraces the idea of diversity, equity, inclusion, and has even equivalent types of programs will be barred from federal.
Yeah, and that's just it's tough, right? It's a challenge. It's another barrier, right? And I just Googled what a definition of health equity is, and you're right. There are many definitions of health equity in this space that we work in. CDC may have a definition, NIH may have a definition, like university may have a definition, but one here, and I'll read this quickly. Health equity means that everyone has a fair and just opportunity to be as healthy as possible, and that people have access to health care based on their needs. Seems kind of simple, easy, but when you talk about what you just talked about, bills being passed, or people who are adamantly trying to put rules and guidelines and barriers, that's just tough and just challenging for the community at large, but specifically the underserved community. And, we've had experience with the PPA so far, but in these groups, in these meetings, or during this session, during this curriculum, we're meeting with researchers or patients and caregivers, advocates. What are some of the common challenges from your experiences or barriers around health-related discussions, and how would you approach overcoming? Because for our listeners, that's what we do in these meetings. That's what we do in these sessions. We have conversations, but we talk about solutions as well. So how would you overcome some of those barriers?
Right. And that is a perfect question, right? So how do we overcome the barriers? I think the crucial piece is we really do, in these conversations, always have to have a clear handle on what the problem is. And there are no shortcuts to it. So it's more than just raising awareness or being knowledgeable about it. Given in our country, depending on where we are, we've got to collect the information on what is going to inform our decisions or development of a solution. Analyzing, well, if we come up with a solution, then what are going to be the impacts, all of the impacts, not only the impacts that we would like to see, but what are the unintended consequences and how do we mitigate that on the front end, as opposed to being pressured to, kind of make our benchmarks and get those percentages in there and then say, well, at least we can say, check. We've done X, we've done our 70 different strategies. And then on the back end, there are consequences that, we'll deal with those later or not. And the people who end up having and experiencing and being most impacted are the patients, right? So it's important to envision what that looks like with them, with everybody at the table. Because honestly, at some point in time, we're all going to be patients anyway, right?
At some point in time.
You go in for an annual checkup, you're a patient at that moment, regardless of what your profession may be. And so being holistic in that approach is crucial. And of course, then taking action and then reevaluating it. I think it's this ongoing cycle that we need to really get comfortable with and to check each other when we feel the pressure, of having to move faster than we are really ready to move forward in a productive way. For me personally, because I'm not directly tied with an institution regarding healthcare or implementing grassroots community health strategies, or with any hospital, I'm not directly involved. I function a lot as a patient advocate for family and friends because of a lot of the insider information that I have. I'm kind of an outsider that I would say I act as an
Alita, you have lived experiences that you fall back on, that you tap into from your public health experience, that you kind of go back in and help folks. So I that's another reason why I know Joe reached out to you and why you're still sticking with this, right? Yeah. Because of lived, right? It's kind of hard to forget about that stuff.
Correct. Right. And I wouldn't want to. I think it's really hardwired in my bones because for me, if I read a science journal, like that is the happiest moment in my life, is to read a science journal. It's weird and quirky, I know, but I get really excited about reading it. And I also really am passionate about sharing with people who want to really gain control of their health.
So I think that's
fuels me.
I think that's a key part because, having someone with your expertise, your lived experiences, who have a passion for reading that information, but you are a translator, like literally you are a translator, but you find ways to also translate the information that you read in that medical journal to the lay community. And I've been an engagement specialist for the patients program for 6 years now. And you know how many times I still hear about it. Okay, Mr. Elliott. Okay, Rodney, break that down for me. Or put that in lay language. Put it in the way I understand. This is one of the reasons why the bridge was kind of created, is because we figured out a way that during the pandemic, folks needed information. They were getting a lot of information via podcast or via social media. So we had to get on this platform to connect with our groups and community members because everyone doesn't have a passion for reading medical journals. Or if they can, get on their phone or when they're walking the dog, they can look at the podcast, or if they're in the gym working out, they can put the podcast. So I know I listen to a lot of podcasts driving back and forth to work, right? So it's about finding that way to get the information. And if you can do that from someone who has a passion for reading journals, I love that. That's great. We talked about earlier about the impact, right? And Patient Professors Academy has had a huge impact, not just during the 6 weeks that the curriculum or the course is going on. A lot of the Patient Professors Academy participants communicate and talk post the graduation. They still stay connected and find ways to be impactful. Have you had some type of impact in your community as a caregiver, or when you put your hat back on from participating in the PPA? And if so, what was that, or what did that look like?
I would say, as a caregiver on a personal level, I wouldn't say kind of globally in the community. And I would say, well, it's pretty clear. There have been some dear friends of mine who had been either diagnosed with cancer since the time I have participated in the program, or individuals who have had a stroke or significant life altering medical situations. And being in the program has really helped me to better help folks to navigate in a global sense through all of the different potential barriers or just confusion that exists. Our healthcare system is extremely complicated. And once you are diagnosed with whatever it is you're diagnosed with, you're scared. And it's a scary place. And for most lay people, we believe our doctor is going to be the person that handholds us. And doctors, unfortunately, they are hand-strung and tied too, because they have their particular metrics that they need to work through. They may have a passion to walk every patient through, but they literally cannot do it because their caseloads are too big. Their obligations to all of their patients are there. So to have someone like me who's kind of outside of the system to say, here, let me tell you, here's this little question here's how you phrase what you can ask, and here's what you can expect the doctor to say back to you, because they're doing patient-centered care, that they are going to be nuanced in certain things, but here's how to literally walk people, friends of mine, family members who are very educated people, to have them kind of decode the language of the system. Being involved in this program has really helped me to do that, and I'm confident with it.
More confident with it. And would you say that there's some type of cultural competence and sensitivity that you have kind of gained from participating in the Patient Professors Academy? Because when we think about it, right, it's very important as a translator, or as a mediator, or as someone in the gap, or someone who builds a bridge, i.e. bridge the patient program podcast. The importance of being culturally competent and sensitive, because that has been discussed a lot in the work that we do here at the Patients Program, even before the PPA was created, but definitely while the PPA is created. I think it kind of spills over into different topics all the time. So can you talk about or discuss the importance of being culturally competent, and how it needs to be discussed and related to health equity from both sides, from a patient side, but also from maybe the doctor.
Okay, the provider side. Okay,
provider side.
Right, because I think of patients and caregivers as being kind of on the same side.
Yep.
It's slightly different twist though, but I just wanted to be sure of what you meant. Okay, so my thought about this, because cultural competence has been around for a long time. Right, there are healthcare systems that have training requirements for their providers. And even some mission statements exist that healthcare systems are going to be culturally competent settings for anybody who walks through their door, blah, blah, blah. And I don't know that the outcomes of all of those trainings is really bearing out, right? It's not clear to me that people who are non-white are actually, if the gap is really closing as a result of all of this competence training, it's not, the numbers are not bearing that out. I don't see that. What I would like to see instead, and this is Alita's pure opinion, I don't know that it can be scientifically done, is that providers become culturally curious, not competent, not sensitive, but curious about the person who's sitting in front of them. Because whatever that individual patient's background is, it can vary from what their training told them, because there's no way to learn completely about all of the varieties of a particular culture.
There's no template.
There isn't. There
Right.
isn't. And so even using the terms, again, I think it starts to solidify these thought bubbles. Well, I'm culturally competent, therefore I know how to interact with this patient. And that might not be true. I mean, you might, but then again, you might not, that may not be true. So I would prefer to see cultural curiosity. And in doing that and being okay with being really direct about asking patients about their cultural background, how we can make the relationship dynamic work, and patients being comfortable with even asking their provider about their cultural background, because in Charlotte at least, there are lots of providers who are from all around the world. And so providers come in with their own sense of culture and how they deliver healthcare too. But that conversation, I think, is a worthwhile one to develop bonding and trust and an understanding of, well, why does this doctor say things in the way that they do? It might be just because of the frame and the lens that they're coming from with their upbringing. And I think that is cultural curiosity is what I would say.
Miss Alita, I like that a whole lot. Here at the Patients Program, when we hear a word or we hear a terminology that kind of sparks, like you said, the bubbles above your head,
Yes.
Being culturally curious as opposed to being culturally competent. Culturally competent sounds like, okay, I've accomplished something, it's done, this is what it is. When you're curious about something, you're interested in trying to learn. And as you're learning, you have to kind of adapt as you go along. And it works both sides. But from the provider side, I totally can understand how that could be a tool you need in your tool bag to help make that interaction, that experience with your patient run a bit smoother, because you want to be transparent. I can hear so many times where community members just say, be transparent with me. Be real with me. Tell me exactly how it is. I can handle it. I can deal with it, right? So if that's the case and you're culturally curious about that, you'll strive to make sure that the patient understands exactly what's going on, or at least have the tools to get what they need post their interaction with you. So I like culturally curious. I'm pretty sure you're going to bring that up this year when you're leading one of our course topics. I'm sitting here and I had to pull it up on the side computer here. You're going to be one of the instructors, proctors, leaders of health equity and research techniques that help reach the patient-centered outcomes research and community-engaged research. So it's a lot of words. I know what that is. We'll get into all that, but what are you most excited about when you're going to be leading and talking about that during PPA this year as one of our lead moderators?
So I generally like to look at my role as I don't know what the word would be, but there's a quote by Albert Einstein that I absolutely love. And the quote is, a problem cannot be solved from the same level of consciousness that created it. I like to be the person who is sparking people to interrogate their level of consciousness. And so I like to present information, and I will again this year, from a perspective of, hopefully my goal is to make people stop and really have a moment of dissonance internally. because all of our participants are self-directed. They choose to be here, right? Nobody is commanded to participate in the patient's program. So we're all on the same page. We're all trying to strive to ensure that all people get equal and appropriate access or equity, if you will, within the context of healthcare. We're all on the same page. We're all on the same team. We're part of the same choir singing the same song. However,
we just may be at a different point along the journey.
Correct. We may be at a different point along the journey and have different rules in that journey, and that's fine.
Okay.
However, we need to be careful of groupthink. And so I view my role as piercing through the groupthink from the beginning, not as a way to burst anyone's bubble, but to open us up to being more creative and getting ahead of a lot of the hindrances that keep coming our way so that we can figure out a way to not be continuously reactive to what the other side, if you will, like the non-equity folks, the folks that want to maintain the status quo. The system as it works is just fine. Thank you very much. But we need to learn to get ahead of them, or to outsmart them, and to not be so reactive. So that's how I view my role. And I hope in the beginning, that's what I'm able to accomplish.
I think so, Ms. Alita. I know I've seen some of the work that a lot of our course leaders or moderators last year have done, even the year before. And each year has gotten, I'm not going to say gotten better, but each year I've seen a different confidence level from both. From our participants being more open and more eager to participate and share their stories. But what you talked about earlier, I just can't get that out of my head. Culturally curious. They're coming with a listening ear. They're not coming with preconceived notions. And then when they do have something, or they do come across something that's a bit different from what they thought, they take time to sit for a while. They take time to listen to it and maybe understand it. Something that we've always been told back in the day is, until you walk in my shoes, you won't know what I've been dealing with. So for researchers and doctors to take their time to kind of walk in shoes about patients and caregivers, I think is essential, is important. And for also the other side, from some of our patients who need these resources and services, being as though that they're involved in these meetings and they're involved in these sessions in the PPA, they understand that the plate sometimes can be a bit full over there from the provider side. But when you have sessions or meetings or folks who kind of want to know and learn from both, that's a start. That's a start. And the Patients Professors Academy is in year 3, and I think it's going to be an awesome series this summer as well. How do you envision things looking forward from your perspective of folks being more culturally curious? I'm like that.
I see you did.
I do.
I see you did.
It makes sense. It literally makes sense at every level. It makes sense for a doctor, provider, or researcher to be more culturally curious. Yeah. We don't have all the answers. I let our community members know all the time. I said, when you work with the patients program, there are researchers, there are doctors that have all these letters behind their name. And they're professionals in what they do because they study, they've had time, they've had experiences that have allowed them to get those letters behind their name. That's great. But Ms. Johnson in West Baltimore community, Mr. Jenkins down there in Charlotte, North Carolina, they've had lived experiences that are just as important when we're working together, when we're talking about research. We're working together, we're talking about community engaged research. There's a need from both sides. Okay. I need 100% of both. That don't mean it's always going to be 50-50. It could be 60-40 sometimes. It could be 70-30, but we're all in this together.
Yes, we all are in this together.
So before we get out of here, what do you envision looking forward? How do you plan on to get folks to be a little bit more culturally curious?
Okay, so what I envision is a time when it's not really that we walk in another person's shoes, because we can't do that. I can walk alongside you and walk with you. But I can't walk in your shoes because my perception of the world and your perception of the world are shaped in very different ways. And guess what? That's okay. It's okay. And I would like to see that moving forward, we really figure out a way to spark and encourage patients to become more empowered, that they can clearly say no, and that's okay too, and not feel guilty. And or feel pressured, and that on the other side as providers, that it's okay for them to say no, because maybe that is the only way that they can safeguard and protect themselves. Because here's the reality. Regardless of the adverse impacts that any of us as marginalized people, Black folks, or folks who speak another language other than English, or individuals who lack resources, who may not have really adequate health care, or who find themselves in rural areas where there's no immediate health care facilities around, or who are never offered research opportunities for some significant clinical diagnoses that they may have. I really do believe that it's important that there is a level of respect,
yes,
and acknowledgement that this system you're still going to be dependent upon, even though at times it may be pretty icky and harmful. But here are some tools that you can optimize your experiences within this system. I don't want the community to just go in hook, line, and sinker, that we figure out a way, and I'm saying we on the provider side, the researcher side, that we figure out a way to cheerlead people in to coming onto our side, because there's some realities that we can't protect people from. Like, we just can't do that. And this kind of goes back to, I'm about to get on my soapbox about the moral injury that I experienced in seeing how some of us can be very passionate about the work that we do, and we are all well-intentioned, and we have a lot of tools at our disposal to convince people to come on in and kind of do what we want to do, because we have our professional, reputation is at stake, or we have our grant and the future grant that's coming up, or, we gotta get that evaluation to get those N numbers up. There are pressures on us too. But I think
those T's and dot those I's.
All of that, right? But I think if we can all come to understanding that maybe there is a place where patient safety takes precedent, the fact that a person can say no, and that they are fully informed autonomously to say, no, I'll take a different course of action, and be okay, and still be here.
Yeah.
In case maybe you'll come back another time and say yes. Like, maybe right now is not the time. And maybe I'm not offering you as the researcher, as the provider, what's going to meet your needs. But here's some tools that maybe you can take with you that you might have your needs met. But I'm going to still be here regardless, because as an entity, if I am really committed to doing good in the world, I'm really committed to doing cultural curiosity, then probably the reason you're telling me no is because I don't understand enough.
Yep, I'm about to say that.
I just don't understand enough. And I have more to learn. And not that I'm going to extract it from you, but can we work as partners in ideas? Can we dance our way through this so that together we can create an environment or spaces or places where your health is optimized? Because there's no person walking on the earth who wants to be unwell. Nobody likes being sick and ill. Nobody like it's just not wired into us as human beings. We're wired to thrive. We're hardwired into our DNA. All you need to do is go to a NICU. You see little infants who can't even speak. You see that power and energy to thrive. It's hardwired in us. We need to create an environment, a society, a system, an interaction, relationships that we continue to nurture.
Well, Mr. Leader, I don't know why you don't realize why Joe sent you an email. I don't know why you don't realize Joe reached out to you to participate in PPA. I don't know why. I have no idea why you don't know that one about, because
Me to go ask him, it'll get back to me.
and you just dropped jewel after jewel here today on the podcast. And we at the Patients Professionals Academy are, it's awesome when we find folks that, enjoy what they do, but then they also enjoy sharing what they do. And they are eager to find ways to communicate that to both sides, to both groups. So this year's session is going to be awesome. I envision it already. And I hope folks understand the importance of wanting to be culturally curious on both sides, particularly from the provider side, but from both sides as well. And with you leading the way and you sharing your experiences, I know it's going to be a great session. So I want to thank you for your time today, joining us on the bridge. I truly, truly, truly appreciate it. And I look forward to seeing you in action during your session.
I look forward to being with you as well. Thank you. It's an honor.
Thank you for listening to The Bridge, your health, your voice. To learn more about the Patients Program, visit our website at www.patients.umaryland.edu.